good morning, depending on where you're tuning in from. I am Lauren Stiles. I'm the president and founder of Dysautonomia International, and I'm very pleased to be joined this evening by Dr. Brent Goodman, who's a member of our medical advisory board and a very distinguished autonomic neurologist who's currently at Honor Health in Arizona. So we're going to do something a little different than the usual Dysautonomia International webinars tonight. We're going to talk a little bit about Dysautonomia International's new effort to try to create better clinical practice guidance or maybe even formal guidelines for POTS because what we have right now is not great. And then we're going to do an interactive session where we're going to ask all of you who are tuned in to vote on and give us different ideas, and we'll capture all of your ideas and we'll summarize them, and we'll actually use that to help inform the development of these guidelines, which doctors are going to have a big role in writing as well. So with that, I'm going to pass it off to Dr. Goodman for a little bit to explain what are clinical guidelines, like why are they important, and what do we have in POTS right now, and is it working for us?
Thanks, Lauren. Hopefully everyone can hear me. Great to see you. Or I guess I can't see you, but it's good to be here. Forgive me, it's been a long day. Um, so very excited about this. I think this is tremendously important. We actually just in November of 2025, were finally successful in getting clinical practice guidelines published for Sjogren's disease. And in those guidelines include guidelines related to neuropathy and dysautonomia, fortunately. And it's a long, arduous process, but I think critically important. And I think, one of the most critical things, it sounds a little bit ridiculous almost, um, but it's really important for clinical guidelines to establish that a condition is serious, right? That it's serious and complex and deserves a set of guidelines and deserves clinical trials to try to get all of our patients better, right? So um, just to backtrack and talk about Sjogren's for a second, that was of such importance to us that the nomenclature for Sjogren's was actually changed from Sjogren's syndrome to disease, with the idea that that nomenclature change would emphasize that this is a serious disorder. It seems to me in the current environment that this is a major problem um, that for many, certainly not for patients, but for many in the medical community, this is just simply not viewed as that serious of a disorder. And I think it's recognized that it's complex, but for some reason that then isn't translated into people thinking of this as being a serious disorder. So I think that that'll be critically important, but this is very challenging, just like with Sjogren's, with, POTS and dysautonomia. These are truly multi-systemic disorders. And so I think when thinking about guidelines, it's really important to get input from a diverse array of people, including patients. And obviously, patients would be, I would say, the most important stakeholders. And so getting input from patients will be critically important. But there are different levels of guidelines, and they can range from those that are very basic, where just a small group of individuals are sitting around and maybe smoking a pipe and say, hey, this is what we ought to do for, or call something or do for X condition. And those are the most basic of guidelines. Really that doesn't involve a systematic or a rigorous literature review. An example of that would be the term a disorder of gut-brain interaction. My understanding is that was much how that term was coined, actually, was a small group of experts saying, gosh, that sounds like a nice way to summarize what's happening with the brain and the enteric nervous system. The next set of guidelines would be those developed by specialists based upon consensus, but there's not a lot of work done with reviewing systematic evidence. And then the most rigorous would be combining experts from different fields, different visions, um, so multidisciplinary, and then there's rigorous literature review, ideally evidence-based, and then one comes to a formal structured consensus. One of the ways that we did this with the Sjogren's clinical practice guidelines was with a Delphi practice, which is where um, it's basically a group gets established, different types of stakeholders, and it's done ideally anonymously with people who are considered to be experts or key stakeholders, and you get input by asking questions sort of repetitively, and one tries to determine if you can generate consensus in a given area, disease space, treatment, uh, diagnostic test, etc. And um, so this is really the goal for us, I think, will be to try to establish a multidisciplinary group, of course, get feedback from all of you, and then try to establish rigorous clinical guidelines that they certainly won't be perfect, but we'll attempt to get them as perfect as we can, sort of aggregating everybody's input to the best of our ability.
Thank you for that explanation of, it's a pretty complicated topic, but it's been done in other diseases, and certainly our patient community deserves it too. And I also want to mention, obviously, dysautonomia is bigger than POTS. There's many different autonomic disorders. And so we're starting this with POTS. Some of the other autonomic disorders have a more um, maybe precise way that they're treated because they're a little bit less heterogeneous than POTS. But after we do this for POTS, we are open to and hope that we'll be able to do it for other conditions. But it's hard enough to do it for one. And I think POTS is maybe by the numbers, the autonomic disorder causing the most disability for the most number of people. So that's kind of why we're starting there. So with that being said, I'm going to turn on this presentation. So you can participate in this through your computer, or if you have a mobile device, you can listen in on Zoom and tune in on your mobile device with the voting. So here we go. Let's see. Hopefully my technical skills can pull this off on Zoom. Okay, here's that. And then I'm going to start the presentation. I have to go back to the first. Sorry, I didn't start at the first one. Okay. So here you go. If you use this QR code, you can check out with your cell phone if you have one, or you can go to menti.com on a different screen than your Zoom screen and enter this code 66081515. Wow, look at the numbers of people joining pretty fast. That's pretty cool. Uh-oh, my computer just said to me it wants to do a software update right now. No. Okay, looks like how many people? We're up to 200 something people. So this we'll just keep this up for a minute to give everyone to get a chance to get in there. It's menti.com 66081515 or scan the QR code on your mobile phone. Okay, let's get started. And the code is at the top of the screen. So if you're joining a little late, it's still up there. So your first question, what is your relationship to POTS? And so this webinar it's meant for mostly patients to give us input, but obviously we know there's always a lot of caregivers who are especially for the pediatric patients who are involved. And there's medical professionals who reached out who told us they were interested in participating in this. And then we have, industry allies or government people or people from other nonprofit leadership roles. So everyone is welcome to tune in. Most of the questions are meant for patients, though. So we want to make sure that the patients really get a chance to have their say. And if you're a parent of a pediatric patient, you can vote on behalf of your pediatric POTS patient as if you were the patient. Okay, so it looks like we have about 70% of our attendees are patients, and it's telling us how many have voted down here on the bottom right, if you guys can see that. Dr. Goodman, can you see this screen? Oh, you're on mute.
I can see it, yes.
Okay, great. Yeah, so we've got a good mix of folks. We love these medical professionals who have tuned in. Thank you for caring about POTS. Some of you are probably both, right? Some of these folks, some of us wear multiple hats. Okay, great. And a good amount of parents on here too. All right, so I'm going to move on to the next question. I think everybody's probably had a chance to vote on that. So this is a little fun. It's anonymous, so we're not really tracking where you live. This is just an image. But if you want to plop your mouse on the screen, where are you calling in from? Yay, Australia's here. Somebody's out in like the what is this? The Galapagos Islands or something? I don't know. Where's my geography book? But probably a lot of US. We've got some European, some folks from India and Africa. That's so cool to see that. POTS is certainly a global problem. It affects people of all races and all backgrounds. And, most of the research has primarily been done on Caucasian women. But we really need to make sure that everybody is counted and that when we write treatment guidelines for POTS, we're recognizing that it's treated differently in different countries and there's different resources available in different countries. So trying to write something that can help everyone is actually kind of hard. Okay, so I think we're gonna move on from this. We've got a good diverse audience here. So this is a question just to help us understand, do people have different experiences based on their sex assigned at birth? It's anonymous, and if you don't feel comfortable answering it, you don't have to. All right, I think when we get up to like 400 on each one, I'll probably move on because the ratio is probably not going to change much. But here we go. Okay, so there's no right or wrong answer. We just are trying to understand a little bit because the POTS diagnostic delay has probably changed quite a bit over time. So if it was less than a year for you to get diagnosed, the next question is for you. So you don't have to answer this one. But I love seeing that the number one is actually getting quite a few votes because several years ago, the most common answer was about 4 to 5 years of diagnostic delay. So, and there's some folks who've kind of had this a very long time and are just getting diagnosed later in life. So they're going to say 50 years or maybe more. But this is really truly like super cool, right? That graph did not look like that 5, 10 years ago, right? So, okay, I'm gonna keep going on this. Okay, so this says correct answer. There's no correct answer. This is just it makes me do that when we create a Mentimeter thing here. This was the standard answer about 10 years ago. So if you were diagnosed in less than a year, how many months did it take you? This is only for the people who got diagnosed in less than a year after the start of your symptoms. Look at that. Some people getting diagnosed pretty quickly. That makes me very happy. Not that I want anyone diagnosed with this, but that diagnostic delay is something that the whole patient community has been working really hard, and the clinician community has been working hard to reduce that diagnostic delay. So it's great to see that in these numbers. Okay, move on to our next question. So this is an open-ended question. You can type a short little answer. There's no right or wrong answer. And then everybody's answers kind of show up on the screen. So don't put any personally identifiable info in here. This is not like your name or address or anything like that. Um, and then when we have a lot of answers, because there's sort of hundreds of people that are going to answer this, we're going to use a little AI tool to help us kind of organize the answers. Although for our actual collection of the data from this sort of interactive survey, we will use your real answers. But just for the display tonight, we'll kind of use AI to sort of sorting the circles from the squares. Okay, this is our first time using AI for this kind of thing. Hopefully it doesn't take too long to do it. So while we're waiting, I'll ask Dr. Goodman, what's the hardest part of being a POTS doctor?
Going to war every day, I guess.
It's taken an awful long time. I'm not sure we're going to do this on all these questions. Okay, these are good answers. Having to figure it out myself, trying to be taken seriously, doctor's not listening. Yep. I think part of this is a little cathartic for us as patients to know that you're not alone, and so many of us have been through this very similar kind of situations. Okay, so here's a good one. Oh, sorry for the typo. That's me. Have you been able to find a doctor with expertise in POTS? And some of us have, and some of us haven't, and it can be really challenging if you can't find anyone. For anybody saying no or not sure, I would encourage you to join your local Dysautonomia International support groups. We have free online support groups in all 50 states, all Canadian provinces, Australia, Italy, a Central South America group, Malaysia, Egypt. And then we have some international groups. We have about 80 different countries served. And then there's some international groups open to everyone. And that's a great place to ask fellow patients who live in your area, like who's good at this around here, and try to get some recommendations. Okay, so looks like a majority of us feel like we have felt that we got a good pot stock. Okay, so here's a question to think about a little bit. What topics would you like to see addressed regarding the POTS diagnostic criteria? So, not about the testing or what diseases you should be screened for, or things like that, but just do you have concerns about the diagnostic criteria that you think that the guidelines should address? Yeah, people are not a fan of the tilt test. Let's see if I try that, grouping the responses again. Tilt test, no tilt test. So this is how it groups the responses. I think we definitely hear from patients on the support groups that a lot of them do have periodic low blood pressure, and there's some confusion, I think, in the diagnostic criteria, whether that can be part of POTS or not. Heart rate, resting heart rate, subtypes. I think that's an important thing that needs to get addressed too. Okay. You can still keep answering this if you're, I think I see more people kind of chiming in with answers. I know it's hard to kind of type fast if we go too quickly. We don't want to miss anyone. We can see there's 300 responses here. Oh, doctor's saying you can't have POTS if you're overweight. You need to find a better doctor. That is not true. That's a terrible thing that we will have doctors just not want to make a POTS diagnosis for all kinds of silly reasons. But there's nothing in the criteria that says if you are overweight or a high BMI kind of patient that you can't have POTS. Dr. Goodman, do you have any wish list items that you want to see addressed on the diagnostic criteria? Not to put you on the spot, but that's fun.
Yeah, it's a difficult issue. I mean, I think we probably most patients and at least most doctors who treat the disorder at any significant frequency should understand the limitations of a test, right? So, an individual on a given day may not necessarily meet the heart rate increment that's been established for POTS. And Lauren and I were just talking before we got going that certain POTS symptoms don't necessarily correlate with findings on autonomic testing like fatigue and brain fog. And and then I would say the other big, I do think trying to understand the mechanisms for symptoms is critically important. And certainly that's what we try to do with autonomic testing, um, but these tests have their limitations. And I think the other topic that is is a challenge right now is understanding cerebral blood flow, and how we might be able to measure that to help in establishing a diagnosis in those who have, typical symptoms but don't necessarily meet the criteria with postural vital sign measurements or tilt table.
Yeah. We had advocated a few years ago at our conference, and we had a sort of POTS experts meeting. We had advocated for the creation of sort of consensus criteria for orthostatic intolerance that doesn't have tachycardia or hypotension. And it was, the patients seemed to like this idea, and some of the doctors did, but there was a lot of resistance to that from some of the established autonomic experts. And so I think it's something that still needs to be done, but it probably just takes more discussion and education and advocacy for that to happen.
I would just say two quick, two more quick things. It actually may be important that somebody doesn't meet criteria for POTS on a tilt table with postural vital sign measurements, meaning, let's say somebody's primary symptom is horrible refractory fatigue. It may mean that something else is going on systemically, right? Um, so, you know, the testing may be important in certain circumstances and really stress looking for other things. And the second point is I saw a comment regarding testing again. For someone, I've said for a long time now, for someone with chronic and ongoing symptoms, the evaluation is actually ongoing. It doesn't end, right? So, we've had POTS patients who we've diagnosed with Sjogren's 10 years later based upon abnormal laboratory studies, for example. Um, so sometimes the diagnosis will declare itself with time.
Yeah. I think one of the things we are really lacking in POTS research and is how the illness changes over time. All the research we
Right.
have, for the most part, is just a short snapshot, usually on a small number of patients, saying this is what POTS looked like at this point in time for these people. But these longitudinal studies that follow people for 10, 20 years, are POTS patients at risk of developing certain cardiovascular conditions, or do some of them develop a more progressive neuropathy situation, or an autoimmune disease? And I think that might be happening in subsets of our patient population, but we don't have research really carefully documenting that. There is a little bit of longitudinal data now. Kate Bourne, who does she got her PhD and she's working on her MD up at University of Calgary with Dr. Raj. And she had looked at some of the Vanderbilt patients from 20 years ago. She reached out to them and followed up with them 20 years later. And, they weren't magically cured of POTS. Most of them were still quite sick. And there were subsets of patients that the small fiber neuropathy patients in particular were doing worse. So I think, getting that longitudinal data and how that plays into the ongoing clinical evaluation is pretty important. Okay, I'm going to move on to the next slide here. We got a lot of answers on this one. Okay, what blood tests should people with confirmed POTS be screened for, right? There's sort of a difference between the evaluation when you're trying to figure out if it's POTS, but once we know you have POTS, what kind of things do we think that POTS patients should be screened for with blood tests? Um, in your clinical evaluation, Dr. Goodman, is there like a standard blood test order that you run on most POTS patients?
Yeah, I think folks here have identified a lot of the important ones from a big picture standpoint. We're looking for mimickers of autonomic dysfunction, which would be, anemia, thyroid, adrenal gland issues. So that basic laboratory screen, and then looking for vitamin deficiencies, as I think has been mentioned, and then really doing, I think, the immune system screening is critically important. The thing that I realize, that being in this field is actually very humbling, if because you realize that you weren't very smart and that you're not very smart. And one of the things that I've realized over time is how many people actually have immunodeficiencies with POTS. It's actually very high. It's higher than I think has generally been accepted, and then really screening for autoimmune and potentially autoinflammatory disorders in patients, particularly with significant sets of symptoms. And like I was saying earlier, where, there are symptoms that don't necessarily match up with what we're seeing on, formal autonomic testing.
Mhm. I think this is kind of fascinating because, a lot of times we're told as patients, like, oh, you shouldn't ask for certain tests, like doctors will get offended, or, that you don't know what to ask for because you're not a doctor. But I mean, these patients are giving us pretty high level clinical care advice here. So I love it. I think our patient community becomes very well informed because you kind of have to be to get good care for your POTS. So okay, great. We're gonna bounce over to the next question. So, not blood tests and not tilt table official POTS diagnostic testing, but what other kinds of tests with people with confirmed POTS? Should they get echoes? Should they get EKGs? Should GI motility was going to be my next one. Small fiber neuropathy screenings. What does our patient community think are the sort of high value tests that we should be getting? And I'm kind of curious in your clinic, what is your probably most common non-blood work tests that you do on your confirmed POTS cases?
Well, the the echocardiogram is, of course, critical, particularly in those with joint hypermobility, at least from my perspective. Um, and then, of course, we do brain MRI quite frequently because of the frequent comorbidity with migraine. And then, depending upon availability, it's GI motility testing. I'm really happy to see that here because I also feel that that's very important. I think many of the patients get labeled with irritable bowel syndrome, which, everywhere I can, I emphasize to physicians that, when we're having discussions about this, that I'm not even sure what that condition is. I'll never put that in a chart, personally. And, for an individual with GI dysmotility, I think that's critically important and hopefully will be an important part of our guidelines, to some extent.
I love that someone mentioned vestibular testing. We just had a lecture today for medical professionals that was on a vestibular assessments that physical therapists can do for people with POTS. So glad someone out there is thinking of that. I think a good subset of POTS patients have some vestibular issues, and it's not really well recognized in the research literature. And I don't know that it's being addressed clinically that often.
We studied that about 11 or 12 years ago. The frequency of vestibular symptoms is above 50% in POTS patients. It's, um, not typically room spinning dizziness, but it can be. It's often more of a rocking and, type sensation. But I think there are important connections that we don't understand very well between the vestibular system and autonomic
Mhm.
pathways.
Yeah. Okay, I'm going to move on to the next slide. So this is not specific tests, but what medical conditions do we think people with suspected POTS, before you're confirmed to have POTS, what do we think we should be ruling out or looking for in suspected POTS patients? I think this is probably one of the greatest challenges for patients and for clinicians because the list of other conditions is very long and it's hard to be an expert in all these conditions, right? What are you seeing in terms of what other clinicians are doing? Are they screening for any of these other conditions routinely, or is it kind of a really short differential?
I think, hopefully most people are getting screened for EDS. The Unfortunately, screening for mast cell activation at this point is problematic. The testing, it just lacks sensitivity, and not everybody agrees upon the diagnostic criteria that should be utilized to establish that diagnosis. Um, and I think that most of the critical ones are actually listed here.
So I'm noticing that on our Zoom, we have 633 guests, and our Menti, we only have 526. So if there's anyone that's on the Zoom that wants to vote, you can go to menti.com and use this code, or, well, I don't have the QR code anymore, but go to menti.com and you can vote here if you'd like to participate in the voting, which we welcome everybody to do. Um, Next slide. Okay, so what medical conditions, once POTS is definitely confirmed, what medical conditions should be screened for? And I suspect for most people this will be the same list, but there might be some nuance difference, especially the way clinicians view it, like what order of operations do you do? When do you screen for what, right? Do you have any sort of rules in your clinic about what you screen for before POTS is confirmed versus after POTS is confirmed?
Um, I think, well, generally speaking, I think, we're doing a search for the typical comorbidities. And then I think for me, at least, one of the decisions is, do we do genetic testing or not? Is genetic testing done for EDS? Um, and then should genetic testing be done, more broadly for all patients? I think, are good questions. That, there's probably not going to be any consensus regarding that at this point, but I noticed I think on the prior slide that it was suggested that we screen for mitochondrial dysfunction. I do think that probably some of the patients, it's probably one of the more common genetic causes of dysautonomia, but actually very hard to test for.
Hmm.
Um, but yeah, genetic testing is certainly a big one. I see tests regarding the compression syndromes as well listed.
Yep. Dysautonomia International is funding some mitochondrial biomarker research at Case Western right now with Dr. Shamali, and they have a big mitochondrial research center there. And we recently, I guess last year, I think it finally published, had funded a time-restricted eating study at UC San Diego with Dr. Taub and Dr. Doherty to see if just slightly shrinking the window of time each day that people eat might improve their mitochondrial and metabolic biomarkers. And there was some improvement in mitochondrial function when people ate basically 2 hours smaller window than they were currently eating. And that wasn't with changing their diet, the content, the healthiness of the food, just sort of shrink the window 2 hours. So I think there's a lot of room for growth in finding new treatments for that kind of stuff, but we're not, nobody seems to be really screening for it routinely right now. Um, okay, so I'm going to hop on to the next slide. Okay, so I think I know the answer to this. Have you been diagnosed with any other medical conditions besides POTS? And anybody saying no, I'm kind of like, did your doctor evaluate you? But I know I'm done trying to make fun because obviously there are some people who just have POTS, but it's much more common to have more than one thing going on. Let's see, probably when we get up to about 400, I think we'll probably keep going. How often do you see people who just have what I would call plain vanilla POTS?
Not very often. I think it's just so access and capacity. It's just a challenge, and so unfortunately, um, what some might be considered more straightforward may not necessarily need or want to wait to get into an
To
autonomic
see a
clinic,
specialist. Yeah.
unfortunately.
Yeah.
So,
So this is, if anybody still hadn't joined in, this is the QR code you could scan with a smartphone and join the voting. Okay, I'm going to keep going here. All right, so if you have been diagnosed with something else besides POTS, what medical conditions? And if I was answering here, this would take me about an hour to write my list. So maybe just give us like the top three most important ones to you. And for anybody who's kind of new to this and trying to figure out what should I ask my doctors to screen me for, like this is a very long, complicated list, and each of these diagnoses has their own criteria, sometimes their own specialists, and can be really hard to kind of figure out what's causing what. Interesting. I actually know a couple other muscular dystrophy POTS patients, and that's something that I think is not routinely looked for. So it's a good list here. I'm gonna wait till we get to a little bit more people having time to enter. So I guess when you guys entered it, it only maybe wanted you to enter one thing because I think a lot of people have more than one thing. Let's see. IST. Interesting. Okay, I'm gonna move on to the next one here. So, do you suspect that you have other medical conditions related to your POTS that you have not been diagnosed with yet? Dr. Goodman, you and I had a talk several years ago, and you told me like the rate of Sjogren's you thought you were seeing in your long-term POTS patients, like people who've had POTS for 5 years or 10 years. Do you do you remember that conversation, or do you have an idea of like what percentage of those long-term POTS patients you're seeing Sjogren's in?
Um, I th
Unofficially.
Yeah, unofficially, it's really challenging because the the diagnostic criteria for Sjogren's at this point require either a positive SSA or a minor salivary gland biopsy in conjunction with dryness. And the SSA frequency or sensitivity is somewhere between 10 to 60 or 70%. And in patients with neurological issues, it's pretty clear it's closer to 10%. So we're really relying on minor salivary gland biopsy quite often, and that's not the be all end all either. It also lacks sensitivity. And uh, I do personally think that there is something about POTS, either pretty clearly Sjogren's can cause POTS or what looks like POTS, and then I do wonder whether people have POTS and then can develop what looks like Sjogren's based upon chronic and ongoing and active autonomic dysfunction. So I actually think it's actually, when we get a heck of a lot smarter, it's going to be very high. It's going to be, I, I don't know, I hesitate to say, but I think it's going to be 40, 50% at least.
Yeah. I think as we've done work trying to raise awareness about this, and the Sjogren's Foundation has as well. There's more patients asking their doctors to be tested for it. It's just as hard to find a doctor to screen you for Sjogren's as it is to find a POTS expert. So it's pretty challenging. But I think there's a lot of awareness, and that's growing. And in some sense, it's one of the more treatable causes of POTS, right? Like there are immunologic treatments for Sjogren's, and there's certain new ones that might be getting FDA approval soon, and potentially approvals in other countries. So I feel like this is a piece of POTS clinician education and patient awareness, not just Sjogren's, but a lot of different things that might be more treatable than just treating POTS alone.
And I know you've emphasized this point before, Lauren, but the EDS actually is probably an additional risk factor for having an autoimmune condition. So I think, some who are very see things from more of an EDS lens, they see everything as, coming from that connective tissue disease problem. But this disorder for many is probably its immune system, its connective tissue, and its autonomic system, nervous system being, revved up.
Yeah,
And so, having POTS, having EDS, even having a mitochondrial disorder, most patients with mitochondrial disorders have autoimmune disorders, actually. Um, so, getting a concussion, as Lauren can tell you, that puts you at risk for having an autoimmune disorder. Um, so I think, unfortunately, a number of the different comorbidities increase that risk.
Yeah. So one of the sessions we're having at the conference this year, we're gonna have a whole like neuroscience symposium on it, not just the sort of clinical lectures, but trying to get PhDs, like people who maybe don't see patients clinically, but do really cool research on autonomic and immune cell signaling. So I think a lot of people don't realize that your autonomic nervous system regulates every immune cell in your body. And so if you have a disordered autonomic system because of whatever cause, eventually, if that's chronic, you are going to end up with changes in your immune cells and how they're working. So I think this is majorly under researched in POTS, but we're starting to see that research in well-defined autoimmune diseases like rheumatoid arthritis and Crohn's disease. And so we're trying to get those kind of research tools applied to the dysautonomia patient community by bringing those people into the research conversations. So this was a barriers question we put in here to sort of help. I think it's important when we write guidelines to understand why people are prevented from getting access to, uh, a good workup. And there's a lot of different reasons here. So I'm gonna pop over to the next question. So this is a little bit about trying to understand what's happening clinically in terms of like we know that people with POTS are told to drink extra oral fluids, but sometimes that guidance from their doctor is pretty vague. I've had doctors say to me, just get some Gatorade and potato chips, right? And that's not good advice for long-term chronic illness treatment. um, so we just thought it'd be interesting to ask this kind of question to see like, what percentage of us are not getting specific advice. Okay, I think our ratio is going to stay about the same if I keep this open a few seconds more. All right, I'm gonna move on here. So same question, did your doctor tell you a specific amount of salt or sodium? I think this is sometimes very confusing for patients to know the difference between salt and sodium and how to track it. And then also, some of our patients are hypertensive when they stand up, right? So they get a little worried, like, should I be taking salt or not? Um, and so having clearer guidance from at least whoever is the primary manager of your POTS, we should be able to get those kind of specific recommendations to our patients. Do you have a standard number that you use, or do you titrate it like based on the patient's urine sample or something?
Yeah, usually we're shooting for 5 grams of sodium. But to your point earlier, there um, are hyperadrenergic states where the blood pressure will go up posturally. But what's interesting about those is usually when you look at the studies on tilt table, those increases in blood pressure are preceded by a lot of fluctuation.
Mm,
So usually we're utilizing the same principles from a volume expansion standpoint, right? You want to, this is a disorder of instability. All of the measures that we utilize are to try to get the autonomic system more stable.
yeah.
Um, all of the treatments. And,
Vanderbilt
when
had
we,
a, oh, go ahead, sorry.
I was just going to say, when we treat an autoimmune disorder, let's say Sjogren's with dysautonomia, what happens is the autonomic nervous system becomes more stable. So we don't have to use medications to manage heart rate or blood pressure. That all normalizes, and these big fluctuations that we see tend to diminish.
Yeah. I was going to say on the hyperadrenergic question, Vanderbilt had a study that they presented at a conference, but I never saw it turned into a full manuscript in a journal article, where they took the more hyperadrenergic POTS patients and they gave them increased oral salt and fluids, and it actually reduced their excessive plasma norepinephrine levels. It reduced their hypertensive response to standing. It reduced their heart rate. It didn't fully normalize it like a healthy person, but it sort of got it closer looking to normal. And so that kind of suggests that some of that hyperadrenergic response is because of the lack of blood flow to the brain, or the upper body sort of receptors that are setting off the sympathetic signaling. So I think that's something that we need, and there should be probably a discussion of that in guidance documents and how a clinician can figure that out. And because I think that most experts don't really, I don't know. I don't think that there's a lot of discussion happening on that. It's sort of, there's a default like, oh, don't take salt if you have hypertension on standing. But what if you could actually get
Well,
rid of that hypertension on standing with salt and fluids?
well, this comes back, I think, Lauren, to the point at the start of the webinar, which is that, the problem here is that this is not considered a serious disease, right? So
Mhm.
um, I'm not sure, quite frankly, people are even paying attention to the intimate details on a tilt table study, for example, to see that
Mhm.
that blood pressure is dropping prior to it increasing on a tilt table study, or paying attention to those fluctuations. It also depends upon your equipment, right? So, but hence the need for the guidelines. I think, again, it establishes the seriousness of this disorder.
Yeah. So it looks like most people are not being told what type or strength of compression to use. And I think sometimes when you're given a recommendation but you're not told what, you're less likely to try it, or you just don't try something effective because it's really not the right type. We do have some research from the University of Calgary group showing that um, abdominal compression is actually the most important place to have compression if you're depending on different types of garments you're going to get. Abdominal is where most of the blood is pooling, and then like upper thigh, and then like full length compression stockings that come like really high up the belly is probably the most effective. Knee highs, there's nothing wrong with them, but they're probably not doing much for your POTS blood flow. They might just make you maybe have a little less edema and a little less soreness in your legs. So, do you have a magical compression recommendation that you do uniform, or you kind of tailor it?
Yeah, no, we talk about tailoring it because, unfortunately, the medical grade stuff is just so difficult for people to wear consistently, at least most people. So,
Yeah.
one smart therapist that I worked with somewhere, um, they use bike shorts, which I thought was kind of clever. To Lauren's point, they can be jacked quite a ways up the abdomen, and then you pull out the little pad in the hind end that protects your hind end when you're biking. So you don't need that obviously in everyday life, and it gets to the knees, and those can be quite compressive. So I think that was a clever option for some patients. But I agree, it's abdomen. Sometime if you're bored, Google venous return or venous blood flow in the abdomen. It's a massive amount of blood volume there.
Hmm. So it looks like most people aren't being given a script. So if you're getting the sort of formal medical compression stockings, they can be really expensive, but most insurance companies and government insurance or agencies will actually cover them with a prescription from your doctor. Most patients, from what I hear, if the doctor writes POTS on the script, it might not be covered. So we have them write orthostatic hypotension, maybe even if that's not your official diagnosis, because they will generally cover it for that. And we, as an advocacy org, probably have to work on that, making sure the insurers understand that there's science that shows this helps POTS too. Um, and even if you don't get a prescription form from your insurance company, you should be able to count it as a medical expense. So sometimes having a prescription from your doctor for it helps you count it as a medical expense, maybe, or your health savings plan, or as your tax write-off or something. Okay, so okay, this is a big one in POTS, the specific type of exercise and the amount of exercise. Did you get any specific recommendations on that from your doctor? And there's, several different POTS exercise protocols that are very specific that have been published. And I think most doctors that are experts in POTS use one of those, but maybe modify it. What is your general take on the exercise approach in POTS? And I know you have done some research on this, I recall.
Yeah, I think this is another area like compression where it does need to, ideally, it should be individualized. And I think what's been exciting for me is to see our um, the engagement with the physical therapists and the occupational therapists and the speech pathologists. Back in the day, I didn't send people to therapy because it was, um, they would the a person would go to physical therapy, they'd see the high heart rate and they would tell them not to do anything. And then the patient
Yeah.
would come back and say, well, you told me to exercise. So now we have therapists working with patients and devising individual
Hmm.
plans. And I think it's really exciting. And I think it should be tailored to what a person has, what their comorbidities are. And if you have EDS, you may not do certain types of exercises, for example. Um, I think we do need to be mindful that some percentage of POTS patients probably have ME/CFS and may have some exercise limitations. So it's important for us to be aware of that as physicians. But also, I think as physicians, exercise, it can be helpful, but it isn't the cure for everyone for sure, as is often claimed.
Yeah. I think there are efforts underway to create sort of written guidance that is designed to be flexible, sort of meet the patient where they're at. We started hosting last year a dysautonomia rehab intensive meant for PTs and OTs and other rehab professionals to come learn about dysautonomias and learn about the rehab approaches that are happening at different centers. I don't think there's one magical, like, this is what everyone needs. But I think it's important to get the views of a lot of different rehab professionals who are working with these patients. And then eventually we kind of, through an iterative process, will find, the best approach will rise to the top. But really, it's hard to protocolize the best approach because it needs to be individualized. And that's such a fundamental concept of physical therapy, right? Meet the patient where they're at, assess them, do an individualized needs analysis. I think that the efforts to kind of create rigid protocols, like everyone with POTS has to do this, is unfortunately has failed a lot of patients, and if you don't have an understanding provider, they think, oh, you're not trying hard enough or whatever. And I've done all the protocols over the last 16 years, and some have helped more than others. Okay, I'm going to move on to our next question here. Okay, so this is just a generic, do you think doctors should have these printed resources for their patients regarding these sort of basic concepts of POTS treatment? Do you guys have, I'm sure you have some handouts or electronic portal documents you send to your dysautonomia patients, right?
Mhm.
Yeah.
Yeah,
I think
there. I was
most,
just going to say there are so many resources, including your organization now.
yeah. Yeah, there's I think most of the experts have some kind of documentation. They give like take-home patient education materials. But there are a lot of doctors who don't see large numbers of these patients, so they don't offer anything like that. And we really have to get more primary care, family care doctors to take ownership of POTS and not say we don't need to send every single POTS patient to Brent Goodman, right? People try, but we don't have enough experts. So we need more clinicians to get comfortable doing the basic management on these patients, and then the more complicated patients who really need a more detailed assessment, should be referred to the big specialty centers. Okay, so looks like everybody pretty much agrees that this is important. Did your doctor ever refer you to a physical therapist to work on a POTS exercise plan? I think we're trying to create more physical therapists who have this kind of expertise, and there really is a lot of interest from the PT professional community. They are seeing this clinically, and they're like, "What do we do with these patients?" And they're learning. It's really, really great to see that. Some of the PTs that we work with at our conference and webinars and stuff have been giving lectures at the American Physical Therapy Association conferences regionally and nationally. There's really a momentum in the PT space, which is great to see. And it's so important that the PTs are trained on what POTS actually is, so that they're not uh, a little bit naive about, oh, exercise can cure these patients. Because I think that's what it used to be. I think that, 15 years ago, if you went to a PT, they would just do like a standard cardiac rehab and be like, you'll be cured, And it's really not that. It's helping the patient get more functional so they can live a better quality of life. So, okay,
And I would just do a shout out to Lauren, to the occupational therapists and
yes.
the speech pathologists who are working in the space as well, because they're working from a slightly different lens and can be hugely helpful
Yes.
there are some similar symptoms in many patients to those who've been concussed, and so sometimes having that expertise of speech path and occupational therapy, um, sort of helping out patients, can be hugely helpful. So it's
Yeah.
exciting to see those experts getting involved as well.
Yes. Shout out to our resident OT expert, Emily Rich, who has done some training with Dr. Goodman, I think many years ago now, and has sort of led the OT field into getting into POTS, which is really cool to see. Okay, so I'm going to keep going on our questions here because I don't want to hold everybody hostage too late. It's already pretty late. Okay, so I'm going to go through these kind of quickly if they're yes or no questions. Have you tried any non-pharmacological, so non-prescription medication treatments for POTS? Or you might even say pharma could count supplements and stuff. Just have you tried non-pharma stuff? And I think most people have. So non-pharma also means like salt and fluids, exercise, compression, eating, changing your diet. Okay, so this looks like our ratio here. I'm going to go on to the next one. Did any of the non-pharma treatments you tried help you? One of the things I think it's so important for us as patients to be mindful of when we're talking on these big support groups with tens of thousands of people is like everyone's kind of different, right? So just because a certain supplement brand was your magical fix for your POTS, it really helped you so much, it might be actually terrible for some other patient. Or, I use vagus nerve stimulation, which I would count as a non-pharma treatment, and that's not standard POTS recommendations right now, but super helpful for me. But I've met other patients who said, "Oh, I tried this and it just gave me a headache." So, um, what do you think overall, just while we're waiting for answers, Dr. Goodman, is the sort of most helpful of the non-pharma treatments that you typically use?
Um, One of the nurses, that worked in our POTS clinic at Mayo a number of years ago, I thought she had a nice description. She described what we call lifestyle measures into a three-legged stool, which I think was kind of a nice
I've seen
description.
that
It
slide.
was, oh, okay. Yeah. Um, and yeah, it was, fluids, uh, salt and exercise. So it's important, but yeah, I agree. I think people trying out different therapeutic options, really makes sense.
Yeah.
Haven't found it yet.
Yeah, that's a big answer, probably a lot of people thinking that. And I hope that seeing what's helping other people kind of maybe inspires some folks who feel like, oh gosh, I've tried everything and I can't find anything to help. There's always something else to try, which can be frustrating in itself to kind of go through that trial and error. It's very hard to do that. So, okay, I'm going to keep going here. What non-pharma treatments have you tried that weren't helpful? I think that's often ignored. We kind of blame patients when something doesn't work. Well, we don't blame patients, but other people do. When something didn't work for you, you must have done it wrong, or you must not tried hard enough, or you must not tried it long enough. But I think patients want to get better, so they try. I know I tried things multiple times that actually made me feel awful, but I was like, but I want this to work, so I kept trying it. Um, I gave myself anaphylaxis a few times trying a drug that I shouldn't have. I convinced myself that I was having a emotional reaction to it, and I took it again, and my neurologist was like, "Are you an idiot? You do?" And I was like, "I wanted it to work." Okay, yep. So these things that weren't helpful, and these are also, a lot of the things that help other people. So that just shows the sort of individualized nature of how we have to do the treatment. Okay, I'm gonna keep going a little quicker here, so we're short on time. Are there non-pharma treatments you want to try, but you haven't been able to access them? And then my next question is actually going to ask you what was the barrier to accessing it. So think about that. So there's a lot of people who have things they want to try that they haven't gotten access to yet. another way I think of the non-pharma stuff is, or really all of POTS treatment is there's no one treatment that gets people 100% better. But if you can get five treatments that get you 10% better each, you might end up 50% better, right? That's like, I think of it as, well, maybe it's legs holding up a stool. You need a lot of legs sometimes. Okay, here, what are the barriers that are preventing you from accessing the other non-pharma treatments? Yep, that's the main answer. Money. And so, like trying to find ways to get insurance to cover more of these, or trying to find more economical versions of them, I think is a big thing that we can work on as a patient and clinician community. Okay, I think it's kind of the same answer from everyone. Guidance, that's probably an important one. I think that's especially with the vagus nerve stim, most doctors are not comfortable recommending it, so people don't know what to do and they're maybe reluctant to try it because they're not sure. Okay, so what non-pharma treatments do the clinicians really need guidance on? What are they not doing a good job in talking to you about as patients? Of course, we're not referring to Dr. Goodman. He's not the one that's not talking to us about this, but our general docs in the wild. Most POTS patients are diagnosed by a cardiologist. That comes from the big POTS survey. It was about 60% of POTS patients are diagnosed and managed by cardiology. So we've got a lot of good ideas here. All of them, yes. Yeah, these are all great ideas. Okay, I'm gonna hop over to the next question. Okay, so this is the same set of questions, just about pharma treatments. Um, Historically, there were some journal articles and some people who kind of said, well, you shouldn't use medications in POTS patients. You should start everyone on non-pharma and make them wait 6 months or a year or something. Do you think that that perspective is still happening in the autonomic field or in sort of outside of the expert land?
I don't see it as much. I think with the exception of one area, probably pediatric at the academic centers, people are more likely to be given exercise recommendate or lifestyle recommendations and sent to pain rehab or something like that.
Yeah. I think that it's another situation of individualized assessment, right? You can't make hard and fast rules about a very heterogeneous condition that has a wide range of severity and a lot of different comorbidities. It seems silly to me to have treatment rules that are rigid, but that's kind of how medicine likes to operate, right? We like rigid rules because, you know, checking boxes on a form is easier than having to think about it.
Well, that this issue gets back to what you raised earlier, Lauren, which is having long-term outcome data. Ideally, it would be nice to know if earlier, more aggressive therapy improved outcomes 10, 20 years from now.
Hmm.
I think one would have concerns about letting a tachycardia go unchecked for many years. What impact does that have on the nervous system, on the immune system, on the connective tissues? So,
Yep. Long list of medications here. So I think, I mean, it makes sense in almost every other disease, early diagnosis and intervention improves the long-term outcome. And so we need those long-term studies to help us understand that if that's true or not in POTS. But I mean, it would be pretty reasonable to suggest that it would be reasonable to assume that it is true because it's true in almost every other disease, right? So this is a good list. None. That's sometimes happens too, right? Okay, I'm gonna hop over to our next question. What pharma treatments did you try that weren't helpful? I think so many of us go through getting weird side effects from these drugs or normal side effects that just weren't tolerable, or we tried them and they just didn't do anything. What are your, Dr. Goodman, do you think that POTS patients have sort of a higher rate of medication side effects than other types of neuropathy, neurology patients?
Yeah, there's no question that's the case. It's it would be tempting to blame all of you patients for that. But I think there's probably more to it than and you know the I think actually it's a very important question, and um, I think the issue is the fillers in the prescription medications,
Hmm.
particularly in those who have revved up mast cell pathways. Um, I also think it sort of ties into the immunoglobulin IVIG. Why does everyone get aseptic meningitis? The frequency of aseptic meningitis and dysautonomia is super high, so it's made me wonder if the autonomic nervous system does something to the blood-brain barrier. Because there are medications that we give that don't cross the blood-brain barrier or aren't supposed to, and the side effects would suggest that it's a central nervous system issue. Um, so I think it's actually a really important point, but
Yeah.
I don't know what the answer is.
I did, quit just by coincidence. A place I was getting my IVIG infusions had a pharmacogenetic testing study happening, and I gave a cheek swab for it. And it came back that I had a super ultra rare genetic variant that gave me a long list of known drug reactions from that drug variant, from that genetic variant. And it was my list of drug reactions that I had had. So it was like a little bit of like, oh my gosh, I'm not crazy. Like I do actually have a weird reaction to Benadryl, and here's why, you know. um, so that's, expensive for some people. If you're not getting it as part of a study, it can be quite costly to do stuff like that. But I hope that as genetic testing becomes more affordable and accessible, that any patient with a chronic disease who's taking medications should would be great if they could get access to that pharmacogenetic testing that tells you sort of how your body is going to respond to different drugs. So lots of people have pharma treatments they want to try that they haven't gotten access to. And so I'm guessing the answer is cost for most folks, or maybe a doctor unwilling to prescribe it. Insurance, yeah. Doctors being jerks. I'm going to put that definitely in the report. Um, Insurance stuff, right? And some of those insurance limitations are because, for certain drugs, because we don't have enough research proving that the drug works in pots. And if it's an expensive drug like IVIG, insurance companies don't want to pay for it unless there's really a lot of research proving that it works. So that's part of what we're doing as an organization is trying to fund more clinical trials, trying to get clinical trials funded by NIH and by European agencies to try to get more research done so that we can prove to insurance that some of these harder to access treatments are worth their insurance dollars. Okay, I'm gonna keep going on this one here. So this is kind of a big question, right? So when I ask this question, I'm asking the patients, like, what treatments did your doctors like not know about or not know how to prescribe properly, or sort of had, something that they needed to learn before they could properly prescribe it to you? Corleone and other non-beta blockers. We were initially seeing a lot of pediatric centers saying they wouldn't prescribe the ivabradine because they were worried it was going to do bad stuff to the kids. Do you still see? I think I see less of it now. Or do you see that? I know you don't see too many really young kids, but like in the broader picture of the teens and stuff, are you seeing a reluctance of pediatric providers to use ivabradine?
That's a good question. I'm not 100% sure on that, Lauren. I would say, interestingly, it may be just unique to our area, but I don't see a lot of cardiologists putting patients on ivabradine in the
Hmm.
first place for POTS, which is peculiar. because we started doing it like around 2010 or so, when some of the studies out of Europe came out. So,
Hmm. It's it's generic now in the US and
mhm.
you can get it pretty cheap, so we're starting to see more people getting access to it. I wouldn't say anything official because obviously everybody's treatment decision needs to be made in consultation with their own doctors. But I think that the ivabradine seems to work better for POTS and doesn't cause the blood pressure drop and the fatigue as much as the beta blockers might. But we are actually funding a comparative efficacy study at the University of Calgary of propranolol versus ivabradine to sort of see if there are different outcomes or maybe subsets of patients respond differently to these drugs. Okay, let's keep going here. So this is the big pick. Overall, if you had to pick one treatment that was the most helpful for your POTS, what would you say that is as a patient? A martini. I want to hang out with that person. I did have a joke one time with one of the autonomic docs. I said, I'm pretty sure the cure for POTS might be sleeping on a beach in the Caribbean with a pina colada. And I'm willing to be a part of that clinical trial if anyone wants to run it. Okay. Or not a pina colada, sorry, a margarita with extra salt. Okay. Yep. So these are all kind of things we frequently hear about. Quite a bit of the immunoglobulin stuff there. Somebody's got an autoimmune diagnosis if they're getting those drugs. All right, I'm gonna go on to here. I think this is our last question. So if you could teach doctors one thing about POTS, what would you want them to know? What would you teach them? You can learn a lot from patients. Yeah, I think there's so much work we still have to do and making sure clinicians know that it's real and it's treatable, not easily, but that it's something that they can use their skills to help these patients. Dr. Goodman, what's your answer to this question? If you could teach other doctors one thing about POTS, what would you teach them?
Well, I agree with, I agree with, I think most of these comments. I had a medical student with me, forgot what day it is. I think it was yesterday. And I said he's going to be a neurologist. He's in his third year. And I said, it's important to have good training. And then for the first couple of years, you sort of um, basically um, coalesce all the knowledge that you gained from residency. And then once you get out beyond a couple of years, who you should really be learning from is your patients. So whoever wrote that you can learn from us, I agree. I think
Yeah.
it's good for us as clinicians to, when our therapies don't work, to not blame the patient, number one. And then number two, really try to stay curious and listen. It's not always super easy because you all are very complex. And there's a lot of failure too, right? So a lot of the things we prescribe don't work. And we recognize that obviously, or should.
Yeah.
So
So, all right, I'm going to turn off the slide sharing and sort of wrap us up. Thank you so much to everyone who participated. It was really great to see all that feedback. We're going to summarize everything and we'll probably make an online version of this too for people who couldn't come to the webinar to really make sure we've given access to all of our different stakeholders to give input and help kind of craft the basis of these guidelines we're going to try to write. I want to give everybody fair warning. It takes years to write guidelines. How long was the Sjogren's one going on? It was like at least 5 years, right?
not that bad.
Not that bad. I don't know. I got asked to be part of the voting committee. I think it was about 5 years ago. But it takes a long time, and it shouldn't be an easy process because it's creating recommendations that are affecting millions and millions of people. So you want it to be very deliberative and thoughtful and well done. So it's going to take a while, but we will have a group of doctors who are invited to help write the core guidelines. And then we'll have a bigger group of people that's doctors, researchers, and patient leaders who will be invited to sort of vote the different individual recommendations that are being made. So I'm really looking forward to that process. And I know that this early kind of scoping process where we asked our patient community what mattered to them is going to be a big part of how we think about writing the guidelines and inform the content that we include in it. So thanks so much, everybody, for participating. Dr. Goodman, thank you for always being such a great advocate for our patient community and a great clinician. Um, and I just want to plug quickly, Dysautonomia Advocacy Day is coming up very soon, and you can participate on Zoom this year. We're actually skipping the DC heat and doing it virtually. So if anybody's interested in that, they can just go to our website and click on the advocacy link, and you can sign up for it. We have meetings. You'll meet with House and Senate offices if you want to participate. Sometimes we get the member of Congress, sometimes we get their health policy staff, which is fine because they do all the work. And we're advocating for increased POTS and dysautonomia research funding at the NIH, at the Department of Defense, which has a big research budget, increased access to clinical care for military health families, which is 10 million Americans. There's one autonomic specialist in the entire military health system who's on our board, Dr. Cook. We need more than one doctor serving 10 million military families. And then the third ask is increasing access to telehealth because of the lack of specialists and the shortage, we need more insurance coverage that will cover telehealth for more people around the US. Obviously, the advocacy stuff is US based, is what we focus on. It's hard enough doing advocacy in one country. I don't think I'm ready to do it in 80 countries yet. But if you are a patient in another country and you want to do advocacy, like by all means, get going, do it. Reach out to us. We're interested in sort of supporting those efforts. But we just focus on the US because the US is the largest, the NIH is the largest funder of biomedical research in the world. So we're trying to get as much money as we can for these diseases with the little bit of resources we have to ask for it. And then the last plug I'll give is our conference is coming up in July. We have just put out a save the date. We haven't launched the registration page yet, but it should be launched probably next week. And we always have an amazing conference. Dr. Goodman's been almost every year since you've been on our board. I think you've been there, and I don't know if you like our you come back every year, so I think you like it. But
Absolutely.
yeah, it's a lot of fun and it's also very informative. It's for patients, caregivers, clinicians, researchers. This year we have a basic science session. We have a teen program. It's really, really a comprehensive event. And a lot of people will go to it and tell us, even if they've been living with dysautonomia for years, they'll say like, "Oh my gosh, this was like life-changing. I met all these experts and like I had a beer at the bar with Dr. Goodman after the lectures." and, I'm not offering you up for beer with everyone, but you know, it's very casual. We have a lot of interaction amongst the patients and doctors, and it's kind of fun to do that. So that's July 9th to 12th in Houston. And I know everybody's immediate reaction is, "Oh my God, it's so hot in Houston in July. Why are you doing that?" But we move it around the country every year. And there are lots of dysautonomia patients in Texas. So they need access to clinician education for their doctors too. And so next year we probably host it in a more, northern city. We bounce it around. So anyways, thanks for being here. Thanks for your time.